Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. I've been a cardiologist for more than 40 years in the Houston area. The focus of this presentation is ACC AHA 2022 Diastolic Heart Failure Diagnosis and Management. So let us begin with the feature presentation. Even though hundreds of books have been written about heart failure, and the United States spends billions and billions of dollars for taking care of patients with heart failure, even though we have a variety of treatment options available for patients with heart failure related to reduced ejection fraction and congestive cardiomyopathy, we have very limited treatment options available for managing patients with diastolic heart failure. A whole book has been written about diastolic heart failure dysfunction by Dr. Ho, and we're going to look at what is diastolic heart failure? Who are these candidates who are having diastolic heart failure? How does diastolic heart failure presents itself? How do we diagnose diastolic heart failure? What options do we have to treat these patients with diastolic heart failure, and what is the prognosis of patients with diastolic heart failure? Typically, diastolic heart failure is a condition where there is evidence of congestive heart failure presenting as pulmonary congestion or pulmonary edema in a patient with a normal systolic function. Typically, a patient who presents with diastolic heart failure is obese, over the age of 60. He or she is on a couple of medications for hypertension, and echocardiography is sort of the gold standard for diagnosing diastolic heart failure, because with the echocardiography we can look at the left ventricular size, left ventricular thickness, left ventricular cavity dimensions. We can look at the left atrium. We can look at the systolic function of the left ventricle, the diastolic function of the left ventricle, any evidence of pericardial effusion, and any other abnormalities that may be associated with the diastolic heart failure. And we're going to talk about E prime ratio, which is a very important number in trying to determine who has fixed diastolic dysfunction and who has some degree of reversible component. Many of these patients are having atrial fibrillation, which may be understandable because of the dilatation of the left atrium due to increased filling pressures that results in stretching of the left atrium, which is more prone for developing atrial fibrillation. Here is a very important fact. 50% of the heart failures belong to the diastolic heart failure category. That is the thick ventricle, left ventricular hypertrophy. They may have hypertrophic cardiomyopathy. It may be seen in patients with aortic stenosis, or it may be seen in infiltrative diseases like amyloidosis. Generally, in the elderly population, they not only have left ventricular hypertrophy, they have a concentric left ventricular hypertrophy. As a result, their left ventricular cavity becomes smaller and smaller, and any volume overload or any increase in salt intake can very quickly put these patients into pulmonary edema. They have a normal systolic function, that is normal systolic ejection fraction, which is greater than 50%. They have impaired relaxation of the left ventricle. Because of increased thickness, the ventricle cannot relax as it is supposed to. It also leads to diastolic dysfunction. There is increased left ventricular filling pressure. And I already mentioned the left atrial enlargement. The diastolic dysfunction may be reversible in the early stages, but as time progresses, the diastolic dysfunction becomes fixed. So no matter what we do, we cannot change the diastolic function of the ventricle. And these people are prone for pulmonary edema because of their small ventricular cavity, because of non-compliant ventricle. They develop fluid backup very quickly that causes pulmonary edema, and it also resolves fairly quickly with diuretics. And I mentioned about the atrial fibrillation. A typical patient presentation may include like sudden onset of shortness of breath. They were doing fine yesterday, everything was going fine. Today they just went out for a dinner, and in the night they woke up with acute shortness of breath, and in the emergency room you see them with hypoxia, pulmonary edema, and hypertension. They generally have elevated high blood pressure. In fact, they have high levels of NT-proBNP. Pulmonary congestion is a hallmark of diastolic heart failure, so much so we rarely ever see like peripheral edema in patients with diastolic heart failure. But they do respond to diuretics quite briskly, and that's one thing where we have to be cautious, because being overly jealous in giving these patients aggressive doses of diuretics could put them into reduced intravascular volume, and because they have small left ventricular cavities, their ventricular volume drops, their stroke volume drops, and they can develop hypotension very quickly. So that's why we need to watch for hypotension. When we are talking about diastolic heart failure, more often than not, it is associated with an underlying condition, such as hypertension, which is the most common condition. Then we have rarely aortic stenosis. And of course, we have hypertrophic cardiomyopathy, which can account for a fair number of patients with diastolic dysfunction. And in the elderly population, over the age of 65 years, you think more in terms of infiltrative diseases, particularly amyloidosis, where the only treatment we have may be limited to one or two drugs. And we also need to address the underlying conditions like hypertension, salt intake, weight, diabetes, and pay special attention to heart rate and rhythm. Because a lot of these patients with diastolic heart failure may be well compensated, but if they develop atrial fibrillation with rapid ventricular response, they are sure to develop pulmonary congestion and may be forced to go to the emergency room. That's why controlling their rate and rhythm is of paramount importance in trying to maintain adequate left ventricular filling. The gold standard for diagnosing diastolic dysfunction is by echocardiography and by mitral flow Doppler studies. We not only do the mitral inflow pulse Doppler, we also do the tissue Doppler, measuring the tissue velocity at the medial and the lateral walls of the left ventricle. And by looking at E prime, which is related to the ventricular filling, in a normal situation, grade 0, which is normal, we have a prominent E wave, which is followed by A wave, which is related to the atrial contraction. And in the tissue Doppler, we see a similar negative deflection of E prime, which is greater than 8 centimeters per second. And here, E to E prime is like less than 8. Like the E prime here is greater than 0.8, so E to E prime is less than 8. In patients with grade 1 with just impaired relaxation, this is the earliest stage of diastolic dysfunction. Here we have a prominent A wave, which is expected in a patient with elevated left ventricular end diastolic pressure, where we expect to see strong atrial contraction causing a stronger A wave compared to the E wave. And the E prime velocity remains same. As a result, the E to E prime ratio is less than 8. In grade 2, which is known as the pseudo-normal, the E wave becomes prominent, whereas the A wave remains the same, but at this time, the E prime, which was like 8 greater than 8 centimeters per 8 centimeters per second. Now it is less than 8 centimeters per second. So this one looks exactly like grade normal, grade 0 in the mitral inflow, but the difference is in the tissue Doppler where the E prime has significantly decreased. As a result, the E prime is less than 8 centimeters. So your E to E prime ratio is between 8 and 15. Then finally, we have grade 3, which is the restrictive pattern where the ventricle can hardly expand. That is grade 3 diastolic dysfunction. It is characterized by a dominant E wave, which is at least 2 or maybe 2.5 times larger than the A wave. E to A ratio being greater than 2. The E prime becomes less than 8 centimeters, or in most cases it is less than like 5 to 7 centimeters per second. And in that situation, the E to E prime will be greater than 15, and that ratio is diagnostic of grade 3 diastolic dysfunction with restrictive characteristics. So the diastolic dysfunction, here are some of the key points that we need to keep in mind. The average E to E ratio is greater than 15 with increased filling pressures. The septal E is less than 7 centimeters per second. The lateral E is going to be less than 10, and some people say it should be less than 8 centimeters per second. The tricuspid regurg velocity must be greater than 2.8 meters per second, and we should have an estimated PA pressure of greater than 35 millimeters of mercury. When we meet all these criteria, the person is supposed to have grade 3 diastolic dysfunction, which for all practical purposes is a fixed diastolic dysfunction. Adjusting the risk factors, which we'll talk about in a minute, we would not change these diastolic parameters. Okay, what are the options available for treating patients with diastolic heart failure? And here are some of the options that are listed here. Diuretics as needed, then SGLT2 inhibitors, that is 2A indication, that is if we are dealing with a patient with diabetes, and it has also been found to be useful in patients with diastolic dysfunction, which has shown reduced hospitalizations and mortality. Then we also have the ARNIs, then mineralocorticoid receptor antagonists, then ARBs. But if you look at this chart here, there's only one recommendation, that is class 1 indication. So basically our treatment choice of class 1 indication boils down to diuretics. That is to get rid of the pulmonary congestion resulting from diastolic dysfunction, elevated left ventricular and diastolic pressure, which may have been precipitated by a recurrent or new onset of atrial fibrillation or excess salt intake, etc., or uncontrolled hypertension. So the SGLT2 inhibitors are the ones which have been shown to reduce hospitalizations and mortality, and that has a 2A indication. But if you look at all the other medications which were tried in patients with diastolic dysfunction, with hypertension or without hypertension, and they all had mixed results. That means the results were not totally in favor of patients with diastolic dysfunction. ARNIs reduced stroke volume, blood pressure, and in a later slide I will show you what the results of the studies that looked at ARNIs in the management of patients with diastolic dysfunction. Similarly, the mineralocorticoid receptor antagonists, namely aldactone or epralerone, they increase the diuresis, but we have to be cautious about potassium excess, especially in the presence of increased creatinine levels. They have been shown to reduce hospitalizations, but this was more so in patients who had the lower end of the LV systolic function. Those who had like systolic function 45 or 50, they found some benefit in reduced hospitalizations. Then the ARBs, which of course help if the patient has hypertension. It helps in remodeling of the ventricle in patients with congestive heart failure due to reduced ejection fraction, but they haven't shown such benefit in patients with diastolic heart failure. They have been shown to reduce hospitalizations. If you look deeper into some of the trials that were done using these different classes of medications, in ARBs, in a meta-analysis of 7,694 patients involving 4 trials, the ARBs had no signal for a benefit. Cardiovascular mortality, there was no change in all-cause mortality. The only thing was a mild reduction in hospitalizations. But if someone is having hypertension, ARBs are definitely a drug of choice in controlling their hypertension, and hopefully it would help to reduce the symptoms and minimize the need for hospitalizations. And if you look at the ARNIs, again, there was no benefit of sacubitril valsartan on cardiovascular death or total mortality in patients with diastolic dysfunction. Just like the other medications, they reduce hospitalization to a small degree. Again, we have to deal with hyperkalemia in patients with declining renal function. And it was also associated with higher incidence of hypotension and angioedema. Now let's talk about the mineralocorticoid receptor blockers, namely aldactone or aplerenone. Again, this showed reduction in hospitalization. All these 3 drugs have shown reduction in hospitalizations to a tune of 15 to 17%. Again, we had the same issue with hyperkalemia and increasing creatinine levels. And in patients with compromised kidney function, we have to be extremely cautious about patients developing hyperkalemia. Just like the ARBs, they found that spironolactone had the greatest benefit in patients who had the lower end of the left ventricular ejection fraction in the diastolic dysfunction population. So ladies and gentlemen, this is a very, very quick synopsis of ACC AHA 2022 guidelines for diagnosing and managing patients with diastolic heart failure. As I said, volumes have been written about systolic heart failure. There are multitudes of options available to treat patients with systolic heart failure, with medications, with devices, with surgery, and many other things. But in patients with diastolic heart failure, we know a great deal of information about diastolic heart failure, the diastolic dysfunction, but we don't have a whole lot of options in terms of trying to reduce the rate of progression of the diastolic dysfunction or to minimize hospitalizations by any substantial percentages. Thank you so much for watching this presentation, and I have a series of ACC AHA guidelines on many topics. Please watch those and recommend them to your friends, and please do subscribe to our YouTube channel, and I will see you in the next presentation.